Pleasure to be with you. Good afternoon. We're going to talk about chronic constipation in long-term care today, and before I even get started, I'll apologize about any colloquialisms I may use during this discussion. It's hard to talk about this subject and not use a colloquialism or poke a little fun here and there, and gosh sakes, we have to do some disgusting things to show the love we have for those who are in our care, and this certainly is one of those areas. There's a definition of chronic constipation out there. Now, when patients define constipation, they do it based upon symptoms. People that have to strain at stool, who have hard stools, who have inability to have a bowel movement. The slide says laxation. By the way, that's doctor talk for a good morning sit down. And then people will complain of feeling that they have inadequately evacuated their bowels. Now, the doc is talking a different language. And physicians typically, throughout history, have defined constipation based on frequency, and typically that has been a definition of 3 or fewer laxations, bowel movements, within any 1 week. That's an unreliable definition. I mean, you got to go by memory unless you're doing a diary of your BMs, which not too many people do. If people do a diary of their BMs, you got to be a little concerned. In order to step away from that kind of a totally frequency-based definition, researchers in this area, yes, there are researchers in constipation, they came up with Rome 2 criteria. And the Rome 2 criteria, which again are a research definition, would be that at least 12 weeks out of the preceding 12 months, there would be 2 or more of the following criteria met. So you don't have to have all of these, just 2 of them. One would be straining at stool more than 1/4 of the time. Another would be lumpy or hard stools. Another would be sensation of not completely emptying your bowels 1 out of 4 times. Another would be a sensation of anorectal obstruction, like there's something blocking you off with 1/4 of your bowel movements. Yet another is manual maneuvers needed to facilitate evacuation in at least 1 out of 4 bowel movements. And not a lot of people will come in and volunteer to you that they have actually done some kind of a manual maneuver, like use their finger or something to get BM out. So this does require that the caregiver be a little bit insensitive to propriety and ask. When I think of this one, I think there's the story of the constipated mathematician. He worked it out with a pencil. Now, the last criteria here is less than 3 laxations, 3 bowel movements in a week, and that goes all the way back to the old historical definition for physicians of constipation. In order to have this meet these requirements and get the diagnosis of chronic constipation, one must also not have loose stools in between times. If a person has alternating constipation and diarrhea, that should set the physician to thinking about a condition called irritable bowel syndrome, and would be an exclusion criteria for the definition of chronic constipation. To give you an overview of the risk factors for constipation, being female is more likely a risk than males, and that works out to be about a 2 to 3 to 1 factor. Certainly, the older you are, the more likely you are to develop constipation, and somewhere between 15 and 30% of all elderly people are going to show constipation. Now, there's a relationship between constipation and activity level and otherwise ill health and so forth, so that if we take the elderly who are in nursing homes, and if we look at the frequency of constipation, the likelihood of constipation, based upon how many people have laxatives written on their chart, that number is somewhere between 50 and 75% of all of our nursing home residents. Being in a lower socioeconomic class makes you more likely to be constipated. If you're not Caucasian, that increases the risk. If you have a lower educational level, if you have a sedentary lifestyle, if you are a couch potato, you're more likely to be constipated. And there are a number of medications, and we'll get into that in a little bit, that can make you constipated. If we look at classification of constipation, not all constipation is caused by the same thing. And there is one category in which the transit time, the time that it takes for your sandwich to make it to the commode, is normal. And so there's something else going on that's causing one of these other symptoms on which we define constipation. Defecatory disorders are problems in actually getting the bowel movement out. It's down in the vault, it's right there by the anus, and there's a problem getting it out. Defecatory disorder. There's a slow transit constipation in which it takes a longer than normal time for your sandwich to reach the commode. And then there can be combinations of the two, defecatory and slow transit types of constipation. What's in a bowel movement? Have you ever asked yourself that? Well, if you have, you got to maybe stop and make a run into your psychiatrist. But let me answer that unasked question. What's in there? Well, a lot of what's in the bowel movement is residue from foods, and particularly important is undigested carbohydrates. Now, undigested carbohydrates, it depends on what kind of a food it is, and you'll all recognize that beans are a problem, and that when you present a whole bunch of certain undigestible polysaccharides or carbohydrates down to the small bowel and then the colon, where they have not been digested by your own digestive enzymes, then the bacteria that are in the small bowel and colon will go to work on these. And when they do, they create gas and break down those undigestible polysaccharides into short-chain free fatty acids. Those are nutritional components which can be absorbed by the body and used. But the gas isn't used, and in fact passes out in various degrees of social acceptability. The stool contains a large amount of water, and obviously if the stool is a diarrhea stool, there's a whole bunch of water in it. If it's a very constipated stool, there's very little water in it, so there's a wide range here that defines a lot of our clinical problems. How much of the salts that we eat make it through the colon and out the other end in the stool depends on absorptive properties of the bowel, and also on the transit time. So there'll be a variability in this, but there's going to be electrolytes, that's salts of various kinds, that are found in the feces, the bowel movement. And finally, there's lots of bacteria in there, and you all recognize that one of the main bacteria that we are found in stool is Escherichia coli, E. coli. You hear a lot about this on even the news when there are foodborne outbreaks of various foods, spinach or something from California that has been contaminated by the fecal material of wild pigs in a most recent case. So that's an issue, and the bacteria make up actually a significant amount of the stool content. I mean, it's a small percentage, but it's a significant amount. Larry the Cable Guy speaks to this subject. He says support bacteria, it's the only culture that some people have. I think we've all met those folks. Colonic motility, what about the motion of the bowels? Well, if you think about it, there's actually two kinds of motility going on there simultaneously. One type of motility is a low amplitude segmental contraction. That means a churning activity of the bowel, and this is meant to mix the intestinal contents, to squish them around. And by mixing them, it means that different parts of the fecal matter are going to be placed up against the wall of the intestine where the absorption process goes on, where enzyme systems are at work, and where things that are in the bowel movement will move across the membranes of the intestinal wall and then eventually get into the bloodstream and become part of the metabolism of the body. That's how water would get back into the body from the bowel movement. That's how electrolytes would get back in there. And this mixing or lower amplitude segmental contractions is what's necessary in order for that to be done efficiently. There are also high amplitude propulsive contractions. These are called peristaltic waves, and they're coordinated in a way that it causes the muscular contraction to push the bowel movement downstream from the small bowel and work its way into the large bowel and then eventually out the anus. The colon is a major place where fluid and electrolytes needs to be reabsorbed into the body, or else the body's not going to have enough efficiency to maintain itself. If you got a lot of bad diarrhea with a serious intestinal disease in third world countries, you know, this is one of the main reasons that people die. So the colon needs to store the feces for a certain amount of time in order to give the body time to reabsorb those necessary fluids and electrolytes. Another reason, though, for storage of bowel movement in the colon is so that we don't embarrass ourselves or have accidents. So that, you know, we're social animals, and that means that you just don't go every time a fecal movement makes it to the other end, out to the anus. We just don't automatically let it go. It has to be stored there until there's a socially appropriate time to make that evacuation. Did that happen because of modern society? Probably not. I mean, this goes back in evolution all the way to lower animals, where the mother would not want to just spontaneously defecate into the nest, because that would be unhealthy for the babies. Also, that would have an odor that would attract predators, so that the predators would know where the nest is and could come and eat the babies. So for a variety of reasons, all of which translate into good hygiene and social acceptability in modern day life, you know, we have this ability to more or less store the fecal movement until it's an appropriate time to have our morning sit down. Grab the paper, get the sports page, and get your job done. Innervation of the colon and small bowel is important in this process of creating the propulsive, the segmental waves and also the propulsive waves. And the actual activity of defecation, of having a bowel movement, is, as I've said, under a voluntary nervous system control. You can think your way through this and say, okay, now is okay, or now is not okay, I need to wait until I travel another 3 blocks in my car, get out of the car, and go to the filling station restroom. The colonic motility, though, the movement of the intestines, is under involuntary nervous system. It's not under conscious control for the most part. And there is a plexus of nerves, it's called the mesentery plexus, that coordinates those messages coming from the low brain and from the spinal cord and talking to the small intestine and large intestine. There are a number of neurotransmitters, nerve chemicals, that tell the bowels and the muscles controlling the movements what to do, and among those is one called substance P that excites the muscular movements. And then there's vasoactive intestinal polypeptide and nitric oxide, which are inhibitory, that tend to relax those muscles. Found scattered throughout the walls of the small intestine and the colon, there are interstitial cells of Cahill. That's a fancy term for little pacemaker cells. Just as we have pacemaker cells in our heart, the brain doesn't say beat, beat, beat. There are intrinsic cells in the heart that tell the heart muscle to beat, 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 thank goodness. And those same kinds of cells exist in the bowels to automatically tell the muscles of the small intestine and the colon to do their movement. Now, those interstitial cells, those pacemaker cells, are very susceptible to or prone to either reversible or even irreversible damage done by a variety of things. One would be cathartic or stimulant laxatives. If you use these too much, they will damage these pacemaker cells so that then you don't have movement because you've whipped a tired mule too much. Other things that would bother this would be certain diseases. The most common thing that I encounter is people who have had bad diabetes for many years. And just like they get peripheral neuropathy where they have pains in their legs and where their toes don't feel or the bottoms of their feet don't feel as well as they should, and therefore they get ulcerations, the same thing is true to damage to these interstitial pacemaker cells in the intestine, so that constipation can occur on a basis of neurologic damage from the diabetes. Once in a while, we get an individual who voluntarily inhibits bowel movements too much, stool withholding. If you have in your charge any children who have mental retardation, who have cerebral palsy, and occasionally we encounter children with psychiatric and psychosocial problems, personality disorders that will cause stool withholding or will give stool withholding. And these folks can get themselves into big trouble because voluntarily withholding the stool too much can lead to actual retrograde or uphill travel of the fecal bolus. It can go backwards the wrong way. It can eventually cause a secondary inhibition of the propagating contractions that move stool along, so that you didn't originally have an organic cause for constipation, but by withholding too much, you can give yourself a permanent damage that will cause a continuing problem with constipation. And certainly that voluntary stool withholding can lead to an increase in the transit time, the time for the stool to pass from the beginning to the other end. Just a word, most of us are not taking care of children, but stool withholding in one very common scenario is coupled with fire setting and with cruelty to animals. And these children have some very serious psychological problems and should be enrolled in some psychiatric care before something irreparable does happen. I got a couple rules for you. Some of these rules you probably already knew. One of the rules is that there is a gastrocolic reflex. When we eat something, shortly after eating, and also after waking in the morning, the gastrocolic reflex talks through the nervous system to the nervous system controlling the intestines, and can lead to or will lead to propensity to have a bowel movement. That is an important reflex, and one that as caregivers we can take advantage of, so that many times it may be a good idea to take your ward, your individual for whom you care, to the bathroom on a scheduled toileting basis after they've had a good meal. Another of the rules, which is not very helpful to us in long-term care, but it kind of helps to explain some things, is that squatting makes having a bowel movement easier. In Western society, we've invented the toilet seat, and we sit down to have our bowel movement. But actually, that does not create the optimal mechanical positioning of the colon and enhance the power of the muscles that we use to control and to push out a bowel movement. And so in undeveloped countries, in the Middle East, many times typically the modus operandi for having a bowel movement is to squat over a trench. And that positioning really does enhance the defecatory reflex. It's interesting also that in those countries where squatting occurs, elderly people have to maintain their abilities, their strength in their legs, the strength in their pelvis area to engage in the squatting. And it turns out that there are fewer hip fractures in cultures where squatting is utilized as a method. Now, moving on with the rules, a small stool is more difficult to pass. That seems a little counterintuitive. If you've got a great big wad of fecal material, isn't that going to be hard to pass? But if you think of it this way, it's easier for the colon to get a grip on something that's large than it is on something that's very small and to push it along. So a large bowel movement actually facilitates easier bowel movement. A hard stool is difficult. That is, if it's dry, if it has more water taken out of it, and a soft movement is easier. So if there's a longer transit time, or if you have, on a voluntary basis, withheld that stool for longer, more of the water has been absorbed, and it's going to be harder to pass. If the individual took less water in the beginning, then that stool is going to be harder. It's going to be more difficult to pass. The converse also being true, that if you drink plenty of water and manage to have your bowel movement shortly after you get the urge, it's going to be easier, and we ought to try to facilitate that. Now, here's a very useful tool, and this is downloadable. Our folks here at can tell you how to get that done if you're not aware. The Bristol stool chart. All doctors hope that someday a disease or a symptom or a physical sign will get named after them. And I'm sure that Mother Bristol must be very proud of Dr. Bristol for having achieved that, since his name is on the stool chart. This can be a useful way, those of you in the audience who are CNAs, it's a very useful way to communicate the consistency of the stool to your nurse, who can then report that to the physician. And we don't have to be using such guesswork. A type 7 stool is entirely liquid. This is runny. This is a problem. We got diarrhea here. A type 6 stool is fluffy, ragged edges, and a mushy stool, and it can be anywhere between normal but a rapid transit kind of a situation, maybe has something to do with what you ate, or it could be conceived of as part of the diarrhea process. Type 5 stools are soft blobs with clear-cut edges, and these are easily passed. This is a pretty normal stool. Type 4 is sausage-like, or like a thick snake. It's smooth and soft, and this is also the kind of stool that makes us smile and have a good day. A type 3 stool is also large and sausage-like, but it's starting to be a little drier. It's got some cracks on the surface, maybe not as pleasant to pass, but not that unpleasant either, not really a problem. You get down to a type 2 stool, now we're getting to be sausage-shaped but lumpy. And this is pretty dry stool. This one could cause some poor sensation when it's passed, either hurt or at least be difficult to pass, require some straining, and be tending toward or be considered constipation. A type 1 stool would be separate hard lumps, like little chunks, like nuts. Very hard to pass, and certainly would indicate a constipated stool. You can see how this could easily be set up on one of your TARs, so that if you're going to monitor the effectiveness of a treatment for constipation in a particularly difficult patient, or for that matter in diarrhea too, you could give a pretty specific answer. And, you know, when we're doing vital signs, we like to check the blood pressure. We get some good hard numbers to work with. We look at the pulse rate. We get some good hard numbers. We check if somebody's got an infection. We get their temperature, and it gives us a good hard number. When we're talking constipation, if we have to use a description of the stool, there's too much room for poor communication. And using this scale gives us a very succinct way to talk to each other and be sure that we communicate well about what is a mundane but a very common problem that really matters to people in their quality of life. There are a number of diseases and conditions that cause or contribute to constipation, and everybody knows that what we eat and how we live makes a difference. So if you have an erratic bowel habit, if we don't set up a good schedule for people so that they can develop a time of day when they're likely to have a bowel movement, then you can actually create some problems. If you have low bulk in the diet, low fiber, that can be a problem. Inadequate fluids certainly is a problem, and many of our patients for whom we care have varying degrees of immobility. When we talked about squatting, the reverse is more true for us. We get people who are bedridden or chair-bound who really don't have that kind of mobility to squat up and down. And not only that, but if they're immobile to the point of being in bed, it's extremely difficult to have a bowel movement lying in bed, whether you're able to lie on a bedpan or lie on your side, because you have no gravity to help you out, and you aren't using the sitting position to widen your pelvis and to relax the perineum. So mobility makes a big, big difference. Mechanical factors can be at play, and if we have a person that's already constipated, we can miss the fact that they become extremely more constipated because they've now developed a stricture or maybe a cancer that's closing up and decreasing the size, the caliber of the colon opening in such a way that stool can't pass. A variety of neurological conditions can bother the nerves that are going to cause the peristaltic waves. Among those would be stroke, Parkinson's disease, spinal cord injuries, multiple sclerosis, a host of others. It kind of doesn't matter what neurologic disease, it's liable to affect this. And it's going to affect it not only through its negative influence on the mobility, but also have a direct effect on the neurologic health of the muscles of the intestines. Metabolic causes exist. This stuff gets pretty technical, but be aware that there are a whole bunch of things that can happen chemically in the body and in the blood that would cause problems through the neurologic system. Again, things like high calcium in the blood, low potassium in the blood, low magnesium in the blood, problems with chronic kidney disease and such. Endocrine diseases, I've already mentioned, like diabetes, but also hypothyroidism. You know, when people are low on thyroid, they're much more likely to be constipated. It's a sentinel symptom of that disease. And there are a variety of others. Among them, you'll recognize pregnancy. Myopathies occur. This is the primary diseases of muscles, and obviously if your muscles are weak, then you can develop constipation on that basis. And then there are a couple of ways that psychiatric problems can foster or contribute to constipation. Certainly constipation is more common in people who are depressed. If you're depressed, you're going to be less active. You're going to potentially eat less, although a few people who are depressed eat more. You may take less fluids. And then the actual chemical effects of depression may also affect the neurology of the colon and small bowel in a way that enhances constipation. The second way that psychiatric problems would contribute or cause constipation would be through the medications we use to treat the psychiatric problems, because many or most of those have the potential to be constipating. What I've said about depression is also true of anxiety, and somatization is written down there because some psychiatric patients who have generally depression and anxiety disorders will become overly fixated on their physical conditions. If they do that, older people often fixate on bowel movements. They often believe that they should have a bowel movement every day the way they did when they were a youngster. And if they're not eating as much and they're not as active, that's not necessarily going to be their normal habit anymore. They may be on an average of every other day, and if that's regular, that's not constipation. But if they consider it to be constipation, they may start overusing laxatives. And in overusing the laxatives, they are basically whipping a tired mule. And if you whip a tired mule, the first thing that happens is the mule will work harder. But you continue to whip a tired mule, and the tired mule will become so tired that it lays down and eventually dies. And the same thing, it's a very true analogy here, and when we think about using laxatives in constipation, if you overuse them, you will actually create a bigger problem than you originally have. Again, there are a plethora of drugs that cause or contribute to constipation, and we'll look at some of those in a minute. These various bullets were constructed from an article written by Dave Thomas, a close professional friend of mine up at St. Louis University, and if anybody can sling it, Dave Thomas can. Psychiatric and psychological causes or aggravators of constipation I've already alluded to these. The constipation could either be a symptom of the psychiatric disease or could be a consequence of the drugs we use to treat the psychiatric disease. I've already mentioned that depression and constipation go hand in hand, but that's also true of eating disorders. People that either overeat, binge eat, and then purge, in which case they're losing electrolytes and fluids as well as the bulk that they've eaten, or those who have anorexia nervosa and just don't eat enough to give the bowels a chance. And we've already talked about voluntary stool withholding as a cause. Some personality characteristics in men tend to predict stool size. Among them is obsessive-compulsive disorder. And a depressed mood and repressed anger actually tend to increase the transit time, the time for the sandwich to reach the commode, and so would contribute or cause constipation. Constipation in women is often correlated to higher somatization and anxiety scores, and this actually leads to lower rectal mucosal blood flow. So what starts out as a psychiatric problem becomes a physical problem. Constipation in the elderly is correlated with somatization, with obsessive-compulsive, being overly fixated on things, with depression and anxiety. Slow transit constipation is more correlated with psychological distress than is the normal transit type of constipation. Larry the Cable Guy said depression is merely anger without enthusiasm. I think he needs a honorary psychiatric degree. Here are some of the drugs that may cause constipation, just some of them. And if you've got a constipated individual in your charge, you may want to go back and look at the drug list after this talk and see if you find any of these drugs on there. Some of the antacids that we use are actually anti-constipation, those that contain magnesium, which is like milk of magnesia. So Mylanta and Maalox tend to foster bowel movements, but those that contain calcium or aluminum are going to be constipating, pardon me. Many, many drugs that we use in geriatrics are anticholinergic. Things that we use for urinary incontinence, things that we use to block stomach acid. Many of the psychiatric drugs are anticholinergic, and these will lead to constipation. Anticonvulsant drugs, anti-seizure drugs, and lots of anti-seizure drugs are now being used for neuropathic pain for a second indication, but they still cause the constipation. Antihistamines, things like Benadryl and Allegra, and whether they're new generation or old generation, are anticholinergic, and so they're constipating. Bismuth, which is found in Pepto-Bismol, is constipating. Calcium channel blockers that we use for hypertension. Calcium supplements. A lot of our folks have osteoporosis, so they're on calcium and vitamin D. Well, that calcium is constipating, and we may need to do something about that. Cholestyramine, this word is misspelled. Clonidine, a common blood pressure medicine. The various diuretics, if you're using a water pill to make you pee more, that's going to take water out of your system and therefore out of the bowel movement and have a tendency to enhance constipation. Epoetin alpha for anemia with chronic kidney disease. Hydralazine, another more rare anti-blood pressure medicine. Iron. Lots of our folks are anemic. Many times the doc just empirically treats with iron, which may be a mistake of another sort. But be aware that iron is extremely constipating, and if the doc has not automatically given a stool softener and perhaps another laxative on a PRN basis, along with an iron prescription, it may be a mistake. Oxybutynin is just one example of the drugs that we use for urinary incontinence, and these are very constipating. Progesterone, more in a younger crowd, but occasionally we see it used in geriatrics. Vinca alkaloids are anti-cancer drugs that are constipating. Pain medications of various kinds are typically constipating. The opiate analgesic, the narcotic analgesics would be the biggest offenders. But even drugs like tramadol or your non-steroidal anti-inflammatory drugs like ibuprofen have a tendency, Vioxx, have a tendency to be constipating. Kerry Cramner is a close professional friend of mine, a former president of the American Association of Palliative Care Medicine. And so he writes a lot of narcotic pain medicine. And he has said, let the finger that writes the narcotic order be the same one that writes the laxative order, lest it be the finger that has to do the disimpaction. And it's a joke, but he's saying something very important there. The docs don't have to deal with this on a day-to-day basis like you caregivers do. And so they may forget that an order for laxatives should be a companion order to the narcotics because the frequency of constipation is so high, almost ubiquitous, that you better just plan for it and be ready. A lot of the psychiatric drugs are constipating. I've said that a couple of times, and here's a list of a few of them with some examples of the percentage of patients who take these drugs who will then show symptomatic constipation. When you have a constipated individual, the doc may a lot of times just shoot from the hip, okay, they're constipated, let's do this. But if you really have a significant problem, constipation, and if it's new, the constipation itself should be worked up. And the workup would begin with some kind of a history. The history would go back and look at a lot of the factors that you've seen on the slides that we've shown. The doc should do a physical exam, and the physical examination would include a rectal exam, the fickle finger of fate, and see if there's something wrong right there at the outlet. We should, in our physical exam, look particularly for signs of any kind of endocrine disease, feeling for the thyroid gland, is it enlarged? We should look at the neurological situation, since so many of the neurologic diseases can cause or contribute to a constipation problem. And again, look into the psychiatry. All of those done with a physical exam. We would expect to see a little bit of lab work when we're working up someone who's suddenly, on a new basis, become significantly constipated. And that would include a CBC, because blood in the stool is constipating. We need to know if the person is becoming anemic. We need to do a chem panel because we're going to look at the calcium and look at the glucose for diabetes as causes of constipation. We're going to do a TSH to look at the thyroid status. We're going to check a sedimentation rate to see if the individual has some kind of an autoimmune disease that would cause it. And I said blood in the stool is constipating, so we're going to get a stool occult blood. The other reason for that, colon cancer. Because if you've got constipation, it may not be because of the blood in the stool as much as it is the constriction of the colon itself by the cancer. The surgeons call that an apple core lesion because it's narrowed down and has the shape of an apple core. The workup would potentially involve some kind of a scope where the doctor would look into the area, and if we only need to look a little ways, we use an anoscope. If we're going to look a medium ways, we use a sigmoidoscope, and if we need to look all the way up, we use a colonoscope. Sometimes the regular doc, the primary care doc, will need to consult a gastroenterologist. Now, the treatment of constipation involves any of a number of laxatives, and I'm going to go through these briefly with you, not to make you doctors that can prescribe, but particularly to make you aware of some of the downsides, some of the dangers of these various treatments. Bulk agents work by increasing the fiber in the bowel movement, bigger bowel movement, easier to pass, but they work when they are taken with water. They are often the first choice that we use, things like Metamucil, Citracel, Fibercon, or just eating a lot of fiber, because they are potentially very safe. But we do have to give you some caution. If the person has a poor fluid intake and you put that fiber down there, you could be asking for trouble. They are contraindicated when there's obstruction. If there was an apple core lesion, a cancer in there, and the problem is mechanical and the stool just can't get by a constriction, then having a bigger stool would make matters worse. Castor oil is kind of in a class all by itself. It's old-timey, but it's still around and increases peristalsis. And it's contraindicated in obstruction. If you have major peristalsis, an increase in the squeeze, and it's running up against a stone wall, you're going to make matters worse. There are several brands of this still on the market. Lubricants work by lubricating the colon wall, making the stool pass easier, and I think probably also lubricate the fecal mass itself. And if you oil it up on the outside, then the colon can't take water out of the stool, so actually a lubricant also preserves stool water, making the stool mushier and therefore more easy to pass. The main thing to worry about with the lubricants is that lots of our patients have minor or major aspiration events. And if you aspirate one of these lubricant oils, it becomes an aspiration, a lipoid aspiration pneumonia. A good example of a lubricant would be mineral oil. Osmotic agents work, they are salts. And by having this extra salt in there that cannot be absorbed well into the rest of the body, it causes water to diffuse into the colon and makes the stool mushier, therefore more easy to pass. Downsides, however, would be flatulence, farting, bloating, and therefore cramping. Again, you need to be very cautious in using these kinds of agents if the person has an erratic fluid intake, because if they're not taking their fluids, you're going to have a problem from the agent itself. And these are sometimes contraindicated in chronic kidney disease and in congestive heart failure because they are salts. And so if they do get absorbed a little bit, and if there's a lot of absorption, it could make these particular diseases a lot worse. Sorbitol, lactulose, Miralax are examples of osmotic agents. There are two kinds of stimulants, and they've got long names, and you probably don't need to memorize these, but these are cathartics. They irritate the colon, and therefore they increase peristalsis. They're contraindicated, again, if there's an obstruction, because you can't pound against a stone wall. These drugs risk what we call tachyphylaxis, which means the more you use them, the less they work. And if elderly people are on their own in the community and they're taking these, it worked real good yesterday and it worked last week, but now it's not working anymore, so then I'll take more. So you take more, well, it works again. But then it stops working so good, so then you take more and more and more. And eventually these people will impact because they've literally paralyzed their colon by stimulating it too much. Again, you cannot whip a tired mule. These are very handy when you use them sparingly as needed PRN medications. Some examples would be Cascara, Senna, X-Lax, and Ducalax. Saline type laxatives are, again, a kind of salt, hypertonicity, causing water to go into the bowel movement, milk of magnesia, magnesium citrate, fleets, enemas, and fleets and phosphorus soda are examples. And you need to be cautious of these if the person has a poor fluid intake. Stool softeners are quite safe. They're a wetting agent, like surfactant, like soap, basically. They're somewhat useful in people who have some problem at the outlet, at the anus, like a hemorrhoid or a fissure that causes them pain, therefore difficulty getting the stool out. But although they're very safe and they're often used for that reason, there's really not much evidence in good clinical trials to show that they do much for the average patient with constipation. Colace and Surfac would be examples of stool softeners. Enemas and suppositories work by local stimulation, the same way the cathartics do, but very locally, right there in the rectal vault. They also lubricate, and they would supply back some water, just on a physical basis, to make the stool more easily pass. Fleets, phosphorus soda, enema, Biscadol, glycerin suppositories, soap says enemas, and I wrote in here my personal favorite. I'm just kidding, but I have seen in the past old doctors write for cool coffee or warm coffee enemas with the belief that the caffeine probably did stimulate the colon. Prokinetic agents increase peristalsis by another way, a chemical way. Some of these drugs are off-label, are used off-label, and are investigational. Some of them have been on the market and now have been taken off. Generally, that's because of a thing called long QT interval, a problem with heart arrhythmia. Not too good idea to trade constipation for a fatal heart arrhythmia. Among the examples of prokinetic agents would be metoclopramide, that's Reglan. Its downside is that elderly people are prone to tardive dyskinesia, this business where they get a tic of their mouth, or their neck, or their trunk. And sadly, if you get that complication of the medicine and you stop the medication, the tic does not necessarily go away. Tegaserod, cisapride, octreotide are other examples. Erythromycin, one of the common old-timey antibiotics, actually is a prokinetic agent. This one does cause a little QT interval with the heart arrhythmia problem, but not very much, and so actually fairly safe and one that can be used, and I oftentimes use it in those people who have constipation due to neurologic changes with diabetes. Naltrexone bromide is a new novel agent that's specifically for folks who have constipation with the narcotics, and it's approved by the FDA only for folks who are on palliative care who have really advanced medical illnesses. This is a little subcutaneous shot that blocks the effects of the narcotic on the colon, but isn't able to get in the brain, so it doesn't block the narcotic's pain-relieving effects. Fiber is helpful, as we said, but be careful if you're going to give fiber. Start low and go slow and gradually increase the amount. If you give too much all at once, they're going to get gassy on you. If you take it slow and you get them up to 20 to 35 grams a day, which is a lot of fiber, you can get a lot of mileage on that. I think I'm going to, let's see, let's get a couple more slides in. Lifestyle modifications And if you're in an institution, you may want to think about some of these things not on an individual patient basis, but what about setting up the entire facility so that your activities, your dietary, your fluid program are all working in combination so that as a population you minimize the problems of constipation in your institution. Routine schedules, using the gastrocolic reflex to promote bowel movements on waking and after meals, getting appropriate amounts of activity for all those that can participate, getting an adequate amount of water in, and getting an adequate amount of fiber into the ordinary diet plan for the whole population. Avoiding excessively constipating foods in susceptible individuals, avoiding constipating medications in susceptible individuals, prophylactic interventions when people have to be on a drug that causes them constipation, like the narcotics. Be sure that we also add something for constipation. Nothing goes right when your underwear is tight, and I'll take a few questions. From Pete. Subject is lactose intolerance. What happens inside the colon of a person who is lactose intolerant? Well, particularly those of us whose ancestors are from Scandinavia and Caucasian, but it happens to the best of us. The older we get, the less able we are to digest milk and milk sugars. Those undigestible saccharides are presented then to the small bowel and colon, where since we haven't digested them, the bacteria have an opportunity to digest them, causing gas, bloating, discomfort. And you can give something like the over-the-counter product Lactaid, so you're actually supplying the enzyme that babies have that older people don't have to digest that milk, or you can avoid lactose-containing foods. Marilyn asks a question regarding diabetes and constipation. Could you explain more about how diabetes affects constipation? Well, diabetes could, on an overall basis, decrease your mobility and therefore contribute to constipation by being more immobile, reducing your exercise. It could change your diet in a way that you would eat less bulk and therefore affect it. But probably most importantly over time, just as the diabetes can cause a peripheral neuropathy with changes in the nerves of the sensory nerves of your legs, your feet, that cause the problems with dysesthesia, with abnormal pains there, or with numbness in the legs and feet. That same kind of damage can occur to the nerves in the intestines, causing the intestines to not have the proper propulsive forces that move foods downstream and present them to the anus for evacuation. Martha asks about overused laxatives. I often wondered why my grandmother used milk and magnesia so often, and now I think I have made the connection. Her mother used to make her take it, make her take laxatives for everything, including fever, colds, flu, insomnia. Is this something that she will ever be able to get away from? She takes things like Fibricon all the time. Is that bad? Well, the Fibricon is not going to get her into trouble as long as she is taking adequate fluids and as long as she doesn't develop some kind of a mechanical obstruction. But can she ever get rid of the damage that she's done? It's hard to say. If she backs off of the cathartic laxative, the milk and magnesia, and do that just like you would withdraw from a narcotic, a little bit at a time, back it off, back it off, back it off until it's gone, you may resolve the problem and get back to a normal bowel habit, or there may have been irreparable, unfixable damage that's been caused to those little pacemaker cells so that the person will now have permanent constipation troubles. I have a question about impaction. Impaction is often diagnosed by our emergency room doctors in the hospital when a person comes from a long-term care institution and they have hard stool in the colon, in the rectal vault. Well, that's not a good definition of impaction, and they forget that that's a sentinel event. That gets the nursing home in trouble, or the ALF into trouble, because it implies bad care. Not all hard stool that's down there in the rectal vault is an impaction. It might come out 10 minutes from now, and it might come out tomorrow, and then it's not an impaction, is it? So I've personally offered a concrete definition for impaction, and that is that you've got to have hard stool and also evidence of bowel obstruction by that impaction. And without that, it's not a fecal impaction, and it shouldn't be considered a sentinel event by the caregivers. For you out there doing the care, be careful not to misuse that word. Impaction is a very serious problem, implying that the person is truly plugged up by a fecal bolus, and they're having nausea and vomiting, and sometimes the vomit has a fecal smell, a poopy smell to it. And that person is in acute surgical trouble. Absent that, being severely constipated is not an impaction and is not a sentinel event that requires surveyors to give your nursing home a black mark. I want to thank you very much for your attention.